So let's continue our discussion. So we were discussing, so we had HSV, VZV, and then we Coxsackie A, herpangina, and then HFMD, and then human papillomavirus 8, 11, 16, and 18. Then we had rubiola virus, part of MMR vaccination, measles, and then we distinguish between chickenpox and measles and explain glandular fever and how it is, how the manifestation are by Epstein-Barr virus and how it looks, gives a similar picture, clinical picture with cytomegalo and toxoplasmosis. And we said toxoplasmosis can respond to sulfa drugs, sulfamethoxazole, shade. And then ampicillin should not be given because it can cause a reactionary rash to anaphylaxis. And this EBV, Epstein-Barr virus, was previously known to be, but now we know that this is not behind hairy leukoplakia, whitish roughness of the skin, and which is found usually in HIV and transplant patients. So immunocompromised patients have a hairy leukoplakia, but EBV is not responsible. Then after that, we started HIV. We said that there were some mouth ulcers, which were the early signs of HIV. In retrovirus HIV, mouth ulcers can be one of the early signs of HIV. And they can also develop oral herpes. HIV patients can also develop oral ulcers. And then we said that oral problems related to the people or patients with HIV were these. One of them was hairy leukoplakia. One of them was oral candidiasis. They let the fungus to grow on the tongue. And then gingivitis and chronic dry mouth was because of the absence of saliva, which was otherwise protective. And then canker sores were the pathognomic of HIV. And then we went to bacterial infection, and we know the scarlet fever was caused by streptococcal toxin Sep A, and then under 4 to 8 years causes sore throat, general malaise, fever, characteristic red rash. When there was scarlet fever, I said red cheeks, red rash, red strawberry tongue. How to spot? We have history of strawberry tongue, which feels like sandpaper, red rash on the body, sandpaper, rough fever, flushed red face. So cheeks are red, but peri-oral pallor. Around the lips, there is pale, which makes the red cheeks more prominent. And which was swollen? Swollen was mononucleosis, glandular fever. That's why I have written the name glandular fever. I would have skipped this, but I have written the name glandular fever because swollen lymph nodes, swollen, enlarged spleen, hepatosplenomegaly, swollen lymph nodes, and then swollen tonsils. Swollen lymph nodes, swollen tonsils, 4 to 8. Okay, so bacterial, scarlet fever, we know red rash, red strawberry tongue, and red cheeks. Now we start our lecture from tuberculosis. I think this is the last class. Okay. So caused by Mycobacterium tuberculosis. It is commonly seen in immunocompromised patients. Remember, oral ulcers or oral lesions in the case of tuberculosis and HIV patient are because of immunocompromised state, because this state let other infections which were otherwise dormant in our or hidden in our body appear. They get a chance to appear. So we have immunocompromised and elderly patients where tuberculosis can form some lesions in the oral cavity. Although 1/3 of global population is affected by tuberculosis, oral involvement is rare. But when it does occur, it is usually due to open pulmonary infection or coexisting HIV. So it is the oral manifestation in the case of tuberculosis is rare, but when you will see it. This is very hallmark, very typical presentation, ulcers or lesions of tongue and lips area. You see, these are tuberculosis, and these oral lesions presence They will not peel off after some time. Here you can see the tip of tongue have deep painful ulcer with raised borders, gradually increasing in size. So it increases in size. This is the granulation. Any part, you know, this is a granular disease, right? Granulomata is formed. Any part of the oral mucosa may be involved, although the posterior aspect of dorsum of the tongue is commonest site. Here it is tip of the tongue seen, but the posterior aspect of the dorsum of the tongue. So even posterior aspect is not important. Just see the dorsum of the tongue. There are odd looking, very suspicious looking lesions, white lesions. And then these are deep, painful. Do not scrap them because they are painful. When you try to scrap them, there will be no bleeding will be later, but there will be pain because they are pain. And then they have raised borders after leaving the ulcers, right? Found in the dorsum of tongue. Strawberry tongue, white. In the case of scarlet fever, the white will peel off. In this case, it will not peel off. And then you will do some patch test, tuberculosis, and then you will see that it's positive for tuberculosis. Diagnosis, PCR, chain reaction, right? Especially in cases with unusual presentation, because we need to confirm, is it because of tuberculosis or something else? Histopathology shows necrotizing granuloma with Langerhans giant cells. You remember Langerhans giant cells? Pathognomic. Histopathological finding in the necrotizing granuloma in the case of tuberculosis. These are Langerhans giant cells. What are these giant cells, Langerhans giant cells? Basically, tissue macrophages. Good. And epithelioid cells, and a Zeal-Nelson stain reveals mycobacteria. You know, this is a particular stain for mycobacteria, which is known as Zeal-Nelson. Zeal-Nelson stain, mycobacteria, Mycobacterium tuberculosis, Zeal-Nelson, Langerhans giant cells, dorsum of the tongue. We have odd-looking, suspicious lesions, which can cause deep, painful ulcer with raised border. This is the only thing we have studied with raised border. Otherwise, they were superficial ulcers. Treatment, combination chemotherapy. Why? Because if you have this kind of appearance along with tuberculosis, the patient is most likely HIV positive. Then the only treatment is chemotherapy, because tuberculosis cannot be resolved because of the coexisting condition of the patient due to HIV/AIDS immunocompromised state. Finally, we go towards the final part of our discussion of the topic, which are fungal infections. And in fungal infections, we will be dealing with these important fungal infections. For this topic, for this our review, we will have candidiasis and angular stomatitis for us. So now we start with candidiasis or candidiasis. Candida albicans and Candida tuberculosis are by far the most important species among Candida species. Albicans, you can never forget. It is found in the mouths of more than 40% of symptom-free population. So we are symptom-free, and among 100 of us, every 40 people among 100 normally have this Candida species in the mouth, but do not cause disease because we are healthy individuals. We are not immunocompromised or otherwise unhealthy individuals. And then overt infection, hidden infection occurs when there are local or systemic predisposing factors. These predisposing factors allow the infection to come out and cause candidiasis. What are the risk factors? There are two types of risk factors: endogenous risk factors, exogenous risk factors. What are endogenous risk factors? Which you cannot control, which you cannot take care. You cannot change infancy. You cannot change your age, old age. You cannot change the pregnancy of the mother because she wants to get pregnant and she wants a baby. So these are endogenous factors, not easily modifiable. Immunocompromised state, once a patient has diabetes or obesity, is very difficult to change. So the state is immunocompromised. HIV, diabetes, xerostomia, dry mouth, vitamin deficiencies, poor overall health are some of the endogenous factors which can lead to a state where the normally existing candida species will cause an infection known as candidiasis. Exogenous factor which you can modify, endogenous factors which you cannot modify. So those factors which you can change or modify are poor nutritional diet, so you can improve your diet, use of specified pharmacotherapeutics, some drugs, avoid cigarette smoking, ill-fitting oral processes, some dentures which are not good, which are not fitted properly, can be a house or party place for bacteria causing certain diseases, render your body unhealthy, making it a good platform for your normally existing candida species to cause candidiasis. Chronic local irritation or trauma, local radiation and chemotherapy malignancies. So these are the risk factors or increase these are the factors which increase the risk for this infection. Denture wearers, immunocompromised state, smokers, xerostomia, malignancy because of radiotherapy and chemotherapy, making you immunocompromised, decreasing your leukocytes, malnutrition, those taking broad spectrum antibiotics and abusing the antibiotics. So 5 Ds of candidiasis you need to remember: drugs, broad spectrum antibiotics, dentures, processes, diabetes, immunocompromised state, debilitation, you are not moving from bed. Some patient got a fracture, he is not moving from bed, is unhealthy situation, and then can be a risk factor for candidiasis. And dryness of mouth, xerostomia. So these are some of the risk factors for this, and these are the details. Malnutrition can be sorted out by high carbohydrate diet. So these are some of the factors, and these are the details which are the risk factors for candidiasis. Okay, now on the left side we have 6 causes of candida overgrowth. High carb diet, high carbohydrate diet, bread, sugar, rice in abundant, getting obese, getting immunocompromised, LDL is increased, diabetes is coming, is also running in the family. Okay, very easy. Excessive alcohol consumption weakens your immune system. Then fermented food feed active candida infections. So when you have active candida infections, fermented food can feed it, make it severe. Then some medications provide the perfect environment for candida to flourish, because you took some broad spectrum antibiotics and it caused death of your fauna of your body, the normally acting bacteria in your body which were helpful. Now candida has a chance. And then chronic stress impairs your immune system and shut down your digestive system. Autoimmune diseases, immunosuppressants. You have autoimmune disease, you will get some steroids or immunosuppressants from your doctor, and this immunosuppressed state will allow candida to overgrow. And symptoms we already know. There can be systematic symptoms, but especially for oral, these are also some symptoms. So especially for the oral, we have angular cheilitis or angular cheilitis, angular stomatitis. Do you remember this? This is one of the common infection most of us have experienced in a few of the winters or summers even, or when the temperature is changing from summer to winter. We have at the angles of our mouth angular stomatitis, angular cheilitis. What is this? It is a skin condition where painful and inflamed fissures occur on the angles of mouth or one or both corners of the mouth. It is not contagious. It is not contagious. Diagnosis. First, let's go toward the causes. So what are the causes of angular cheilitis? Collection of saliva harboring bacteria. So there is a collection of saliva which lets the bacteria to overgrow. And then some of us also licking it to make, oh, it's dry, saliva is not reaching, bacteria cannot party. Let's lick it again and again. When we lick it and try to make it dry, actually the saliva reached to this place and saliva and the bacteria wanted saliva, so they are parting again. So use some ointments or Vaseline or some soothing effects. So cover it. Don't let saliva to go there so that bacteria can have ongoing parties. So causes: collection of saliva harboring bacterial infections, allergic reactions of skin or fungal infections. That's why we are reading here. Eczema, excess skin around mouth, inflammatory conditions, inflammatory bowel disease, example, and then vitamin B deficiencies. Very okay. Causes, and then we go for the diagnosis. How to diagnose them? We get a swab test, take swab, and then blood test. Sign and symptoms: bleeding or blistering on the corners of mouth, one or both, skin crackling and crusting around this area, and then redness and swelling. Worse when individual licks lip because it got dry and you lick the lip and the area and you provide the saliva for the bacteria. Actually, you're also responsible for worsening of the disease. And the treatment: applying petrolatum or petroleum-based lip balms or emollients like Vaseline or any lip balm. Oral rinse is important. And then topical cream like antifungal or antibiotic ointments. If you have done your swab test in a hospital or lab, then it came positive for fungus or any bacteria, then you can use antibacterial, antifungal creams. And then we have candidiasis. After angular cheilitis, we have candidiasis primary and secondary. So you can see primary oral candidiasis and secondary oral candidiasis. Primary include acute, which are pseudomembranous and erythematosus. Then there is chronic, which is hyperplastic, and then candida associated lesions. Among these, the importance are pseudomembranous and erythematosus, which are acute, and hyperplastic, which is chronic. So usually in the chronic candidiasis, we see it hyperplastic, and in acute state, we see it pseudomembranous and erythematosus. What is pseudomembranous? Pseudomembrane, false membrane like, looking like. So it looks like a false membrane, not a proper membrane. Pseudomembranous candidiasis. And then erythematosus will be red looking, appearing redder more than white. So you see it's look like a false membrane, whitish grayish membrane. And here it is red looking, appearing red. Erythema is red. Erythematosus candidiasis is red looking, right? And these are acute, acute, pseudomembranous and erythematosus. And then we have chronic, hyperplastic, later in the slide. And then secondary to other oral manifestation. So now we go for the pseudomembranous candidiasis, which is also known as oral thrush or thrush. You see, this is pseudomembrane, false membrane, not hairy leukoplakia. Affects 5% of newborn, infants and 10% of elderly debilitated individuals, bedridden, bedridden patients which cannot leave the bed, or post-operative patients which cannot leave the bed. Diagnosis appears as creamy, light, adherent plaques on an edematous oral mucosa. So red-looking mucosa, the background is red, and then we have white-looking patches, white-looking, creamy, shiny, adherent, close to each other, continuous patches, usually also on cheek, palate, and oropharynx. But if seen, it will not leave the tongue as it is. Some manifestation will be also on the tongue to distinguish from some viral infections. Occasionally symptomless, but more commonly cause discomfort on eating because there are lesions, discomfort, and cause burning sensation and bad taste. Plaques be gently striped off, leaving a raw undersurface. If you apply gentle scraping, you can remove. Unlike some of the bacterial infections and viral infections, you can gently scrape them out. You try to scrape them gently, softly, avoid causing pain, and they scraped off, leaving a red edematous raw surface. Maybe oral thrush. Swab test. Perform a KOS swab test, right? Potassium hydroxide for fungal, and you will know the diagnosis. And these are creamy light adherent plaques, continuous to palate, oropharynx, oropharyngeal isthmus, and then tongue. Okay, thrush. Now we know something about acute pseudomembranous candidiasis. Thrush, you can read by yourself. What is the treatment? What is this? This is a fungal. So there should be azole, azoles. There should be azoles. Fluconazole and itraconazole, very effective. Fluconazole, itraconazole, very effective. Topical Nacetin, miconazole, limited benefit. We don't want to remember you. But we do not want to forget you. Fluconazole, itraconazole, effective. We cannot you fluconazole, itraconazole. And chlorhexidine is for effective adjunct therapy, which gives some symptomatic relief. And if it changes into systematic type of candidiasis, you can also give fluconazole, voriconazole, and amphotericin B. Caspofungin, not so much. Fluconazole, voriconazole, itraconazole, amphotericin B. Cannot forget. Candidemia, candida in blood. If you found candida in blood, 14 days after last negative culture and the resolution of signs and symptoms, remove catheters because it is contagious. And if there is vaginitis, miconazole, clotrimazole, fluconazole. So we have fluconazole, and here you can also give fluconazole. Okay, perfect. And then we have edematous candidiasis, which is red, shiny, atrophic appearance. So this is not whitish, creamy appearance. The other one was whitish appearance, acute one. And this is also acute, but it is edematous, reddish, shiny, atrophic appearance. And then there will be coexisting area of thrush, also known as acute atrophic candidiasis. Atrophic, acute. We already know this is acute, but it is also atrophic. We have smooth, red, flat, raw, atrophic tissue areas. Smooth, flat, red, and raw. Red areas of atrophic tissues. Atrophy is weakening of tissues. So you see some atrophic tissues, right? How to treat them? Eliminate the cause. If due to inhaled steroids, avoid steroids for some time. Rinse mouth with water and chlorhexidine mouthwash after inhaling, and use a spacer device. You know what is a spacer device? Asthma patients. Otherwise, as for thrush. And if this is not the cause, Then whatever you go for the oral thrush, fluconazole, ketoconazole, amphotericin B, you can also give in this condition. Next, chronic candidiasis is a chronic multifactorial with local and systemic precipitating factors caused by trauma, denture, iron deficiency, vitamin B12. It's chronic state. It's not acute anymore. We have red, we have cracked, macerated skin at angles of the mouth, and then tongue is crusted and cracked. And in investigation, you have to perform CBC because this is chronic, and we are afraid of what? Candidemia. And then if there is presence of candida in blood, treat for 14 days. So this is candidiasis affecting different parts of our body, nails, vagina, mouth, skin, organs. And that's the end of this slide.